Hey everyone, welcome back to Bright Spots in Healthcare. You are watching our YouTube channel and you're behind the scenes with our illustrious panel as we get ready to talk about how AI is advancing the member journey and improving lives today. We will be starting our recording in front of our live audience in just a moment. All right, folks. So we got that going. We're about 15 seconds away from starting our live show. All right. I'm going to start us off. Have fun, everyone. Thanks again. We'll not debrief, but we'll say kind of quick goodbyes after I say goodbye to the audience at the top of the hour. I know some of you have a hard stop. If you have to vault, that's totally get it. Thank you for doing this. Hello again, everyone. This is Eric Laser, and welcome to another live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform you, but also unearth bright spots, successes, things that are working at hospitals, health plans, and other healthcare-related organizations around the country. Our goal is to identify as many of those bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this strategy of finding a bright spot and cloning it is the most effective way to improving healthcare in our lifetime. And that's why we do this podcast. And if you have not subscribed to Bright Spots in Healthcare to gain access to the library of unbelievable ideas and thoughts and success stories around the country from leaders across this country, I encourage you to press subscribe on whatever podcast app you like consuming shows. Type in Bright Spots in Healthcare, press subscribe, and gain access to all of that knowledge. None of that costs a dime for any of you, by the way. And it would really help. It should really help give you new ideas to bring back to your organization. And if you really like the show, please rate us and maybe put in a few comments that allows more folks to find this podcast. Our topic today is certainly a hot one that we are all talking about within our organizations, and we've brought some really pragmatic applications to how artificial intelligence is changing the member journey today in healthcare. And we have this incredible panel in front of you today. We're going to save time as we often do because we're tight on time as we always are. We're not going to give each one of these illustrious panelists a full bio read. We will introduce them by title and affiliation, but if you want a sense of the incredible experience and expertise you're about to benefit from, our producer, Gene Ware, is going to put a link to their bios within the chat for you attending live. And if you're listening to the podcast, we'll put it in the show description so you could click on it with your finger and be able to access their full bios. We have in front of you Dr. Nathan Dean. He is the section chief of pulmonary and critical medicine at Intermountain Medical Center. We have Rachini Musavi. She is in charge of all analytics, the CAO at UNC Health down in North Carolina. And we have Dr. Karen Murphy. She is the executive vice president and chief innovation and digital transformation officer, super cool title, at Geisinger. And last, and certainly not least, Ohad Pollack, all the way over in Israel, runs all of marketing, the CMO at TytoCare. Really appreciate you all being here. Incidentally, TytoCare is our sponsor for today's episode. They're a close partner to the Bright Spots in Healthcare podcast and webinar series. As many of you who often attend know, they're the world's leader in enabling providers to practice healthcare virtually. Imagine remote physician exams from your home being done the same quality with the same kind of data collected within a clinic, but doing it all from the home. This is what TytoCare enables providers to do and enables consumers to get the best possible care they can get from the comforts of their own home. I'm going to tell you a little bit more about them later on in the episode, but I want to get right into it because we have a ton to cover So I want to bring in our first panelist, Dr. Nathan Dean. Again, he runs pulmonary and critical care for Intermountain Medical Center. Nathan, you were recently featured in an article in Becker's Health IT talking about AI and updates to a program called pneumonia, an app which utilizes artificial intelligence to aid clinicians in diagnosing and treating pneumonia. Can you tell us a little bit about pneumonia, what it is, so the audience understands it, and then how it works?
Yeah, thanks, Eric and Jean, for the invitation. E-pneumonia is real-time electronic clinical decision support that is embedded within the Cerner electronic health record. It's been running live for 12 years in our 4 emergency departments in the Salt Lake Valley in Utah. And in 2018, 2019, we spread it out to the rest of the legacy Intermountain hospitals across Utah and Idaho. It's targeted for emergency department physicians and then secondarily hospitalists and critical care physicians, and it provides real-time support for diagnosis and treatment of community-acquired pneumonia. It starts by looking at every patient real time in the emergency department and finding patients who might have pneumonia based on 50 different elements, starting, of course, with chief complaint and age and whether they have a fever or a cough and so forth. And when it finds a patient with reasonable likelihood of pneumonia, then there is a P alert put onto the electronic tracking board that identifies the patient for the bedside clinician as a possible pneumonia patient. And then when they launch e-pneumonia, it provides a % likelihood of pneumonia. We are using CheckCD artificial intelligence model from Stanford integrated with e-pneumonia for the last year or two that provides the radiographic findings rather than waiting for the radiologist or trying to do natural language processing. It's open loop, so the physician can look at the patient, looks at the data behind the recommendation that's supplied to them on a screen, and then says yay or nay as to whether or not the patient has pneumonia. And then after that, in the same sitting, it proceeds to objective severity assessment scoring, a recommendation for hospital, ICU, ward, or home care, and then goes on to assess for resistance of potential organisms, recommend specific antibiotics and specific cultures and other microbiology tests. And finally, is integrated with computerized physician order sets that are tailored to that site of care, the risks, and so forth.
Okay, and I don't want to go deep into the impact and results just yet. I want to hold that for later on in the show. But I do want to just to make sure we level set. We're looking to allow physicians. You're looking to reduce diagnostic error. You're looking to improve your ability to triage. You're looking to ensure a doctor has a pathway to best practices more effectively. Any other things that I'm missing there that this initiative is designed to do?
No, that's you've summarized it very well. And our philosophy is that we guide the physician, give them information. It's the combination of the physician and their bedside clinical judgment with the structure of the AI tool that yields best practice and best clinical outcomes.
Great. I want to, because we're going to have this recurring theme for everyone around when something new and exciting that's actually working. We'll get into how it's working later on again. But it's so important to get this to be effective. Any new technology, but certainly as we're thinking about AI and machine learning and generative AI and all in between, that the implementation process is well thought out. And it all starts with implementation and the thought process and strategy that goes into the planning that goes into to it. So could you, Nathan, tell everyone a little bit how you thought about the pneumonia program prior to implementing it and how you went about implementing it so it is in a position to be successful?
Yeah, it would just be wonderful if we could just come up with nice AI and have everybody adopt it on the first day and change the way they take care of patients. But we all know the real world is different than that, and that you have to work with people, show them how it works. And the deployment, we've actually published 2 papers, one about the deployment into our rural sites and the other into deployment in our bigger urban hospitals. Talking about how we get frontline clinicians from the start involved with designing the pneumonia tool, making it user-friendly, and then having local champions and bedside teaching. It's been called academic detailing by peers. We also have used nurses that teach the clinicians as well as the support staff about how to use it. And then we monitor over time electronically utilization, not whether they follow the recommendations, but if they just use the tool. And there is see on the internet, how do we say this? Within Intermountain, the month-to-month utilization by site and by physician is displayed. And then that's made available to the bedside clinician and their leadership.
That's great. I want to get more into that later on. That is really awesome. And just a great first example of how AI is being applied today, because there's this mix of excitement and cautiousness and or skepticism in our industry about this cool and new emerging technology that obviously Microsoft and Google have brought into the populace and the popular media right now. I want to continue with the topic of early detection. I'd like to bring in Dr. Karen Murphy. Karen is like I said, maybe the coolest title on the show, EVP and Chief Innovation and Digital Transformation Officer at Geisinger. Karen, could you provide an example of how you guys are leveraging AI or machine learning to impact your members' journey?
So I can, Eric, and thank you for inviting me here today. I do have a cool title and a cool job, but it's a tough job. Because we always say to really impact meaningfully in cost or quality outcomes is very difficult. But the example I share today is one that we feel meets that definition of meaningfully impacting cost or quality outcomes. And it's an AI application that we're working with an external company called Medial. We have been working with them for the past 4 years on colon cancer detection. So at Geisinger, we're a value-based system. We put a lot of effort into identifying open care gaps. So and colorectal screening is one that really rises to the top all the time. So what this algo marker does is examines hemoglobin levels, and there is a portion within the hemoglobin that the algo marker identifies that this patient is at a higher risk for colon cancer. So we took a look at all of our population that had an open care gap for colon cancer screening, colonoscopy. We identified those in that group who were at the highest risk of colon cancer, and we do this on an ongoing basis. We turn that list over to our care gap closure team. They reach out to the patient and share the fact that they've been identified using new technology that they're at higher risk for colon cancer, and let us schedule a colonoscopy for you. The results have been really impressive. So we've screened annually about 506 patients that were identified in this group. 1 in 13 were identified with colon cancer. And we estimate that we saved 5 to 6 lives a year. And I think that's the most gratifying, is that many times when you're playing with this stuff, it's really implementing these technologies, it's hard to really get a hard quantification. But the team is really inspired that they can say that they save lives through this colon cancer detection. I think to go back to Dr. Dean's point about the challenges of implementation, which we certainly have in other applications, the nice part about this one is that we really don't have to interfere with the clinical workflow. It is actually implemented quite easily by this care gaps closure team that can hone in on these patients that are higher risk, and then they just go on normally and are scheduled for colonoscopy and follow-up. So we're thrilled with the results. We're thrilled with the results and look forward to continue expanding. We'd like to automate the piece of the care gap team. Instead of having a human intervention reach out, we'd love to be able to do that in a more automated way. But until we get that done, we're remaining with the human touch.
It's great. That's great. I want to talk a little bit now, or a little bit more now about triaging and in the business of healthcare and how AI is impacting it directly. First, though, I do want to quick little PSA. One, we're not going to have a ton of time for questions for the audience, but I'm always looking for help in moderating. So if there is interesting follow-up questions that you have while our guests are speaking, you put it in the Q&A module. Gene and I will be tracking that and happy to try to integrate them into the flow of the conversation. If we get a question that we can't answer live, we'll try to answer it in written form. So definitely use that Q&A module. Also, I'd like to think my entire team would never want to go on a break or vacation because everyday working is a vacation for them. But we do have families we want to spend some time with. I'm sure all of you are sifting through vacations this summer. So we're going to be taking a little bit break from the show coming out of this episode. If you want to attend our next episode live, we're going to save you some time from registering. It's on August 31st. So we're going to be talking about gaps in care strategies, but those last minute gaps in care strategies for those of you, especially in the Medicare Advantage space, where you have to get in some of those HEDIS scores as the year nears an end and the summer nears an end. So if you want, we have a great panel we can put together. And if you want to save time and join us live on Thursday, August 31st, 12 p.m. on the East Coast, regular start time, we're going to put up a poll. And if you click yes, we'll pre-register you so you don't have to take the time to do it as you often do through the website. Okay, I'm going to bring in now Rachini Musavi. Like I said earlier, she's the Chief Analytics Officer at UNC Health. Yeah, Rachini, I want to talk about now how you're integrating technologies, whether it be machine learning or all the way down to generative AI, to make a positive impact on the UNC business, and how maybe you're leveraging the technology to determine where people should be to get their care, whether that be in the ED, whether it be somewhere else within your hospital, or maybe it's outside of the hospital. Can you talk to us a little bit about that?
Yeah, thank you, Eric, and thanks for having me on the show. So I think that, if we really look at where healthcare is going and where hospitals are going and the trends in terms of some of the headwinds that the hospitals are facing, there is a great need for us to look at alternatives for how we can take care of our patients in various ways. Care at home, acute care at home, is something that is growing in terms of trend as well as in terms of popularity across hospitals and health systems. UNC Health decided, as soon as we decided to start an advanced care at home program, the doctor that was over that program, Dr. Adaya Kumar, reached out to my team of data scientists and asked for that collaborative support for us to build out this program together. And that really set us on a course to work and collaborate together to come up with a way to best identify the patients that would be great candidates for advanced care at home. Now, there's good things to say about advanced care at home in and of itself, right? It is a great innovation for healthcare. I think it's something that if you're interested in that, we did collaborate on Ed Marx's new book, The Voices of Innovation. I've got my copy right here. There's a lot more details on it on page 36 if folks are interested in reading up on it. But the reason that we want to share this is because, this is one of those trends. This is one of those great missions in healthcare where we all have a responsibility to help shift the conversations and the way that we do things. In bringing in my data science team, we actually partnered to build out a model that would allow us to look at over 276 patients that come through our ED at any given time, score them based on the model, come up with a recommendation, which out of that 276, 103 might be recommended. Of that 103, we might strongly recommend only 18, which, as you can tell, when you have that many patients without the AI, you're having folks manually go through and find those records, dig through trying to identify if they're a good candidate for it. But the AI simplifies all of that. It makes it easy for the clinicians, the caregivers, the folks involved in that process to bring down the numbers to dose those 18 strongly recommended to fit our advanced care at home capacity of only 15 beds, right? And so with this program, what it allows, once we find the best candidates, we're then able to either virtually provide care to those patients who are getting hospital care at home, or in some cases, send out in-person care to those individuals. And as you can imagine, for all of us, we all prefer to be in a comfortable care setting where we're surrounded by our loved ones. And in doing so, we've actually seen some really impressive outcomes from the program for the 2 hospital locations that we're currently doing this in, where the patient satisfaction scores are much higher in these settings, as well as the hospital-acquired pneumonia, or not pneumonia, I'm sorry, just hospital-acquired infections rates have actually improved significantly as well. So really good things to come. We're measuring and continuously monitoring the things that we want to see as well, things like measurements around cost savings, things around readmission rates, and other things that matter in healthcare. But those things are gonna probably improve as we get better at doing the program, as well as measuring the outcomes from it and choosing the best candidates for it.
So patient satisfaction's going up, HAI is going down, cost savings and those readmission rates pending. How did you choose the 2 hospital locations? Was there a certain profile about those hospital locations that were attractive?
Yeah. Well, we have 2 of our biggest hospitals. We've got our flagship hospital in Chapel Hill, as well as our biggest community-based hospital over in Wake County in North Carolina, where our capital is. With them being our 2 biggest hospitals, being able to start a program at those 2 locations really helped us to identify and get our footing in terms of how do we do this? What does it look like? Does it actually add value? And from there, it allows us to determine whether or not we can expand. And if we expand, how would we best do so?
And as from a clinical quality standpoint, have we determined, are the people that are being chosen to get their care at home versus what would typically be in the hospital? Have we determined, has that sort of that methodology, has the AI worked to effectively triage so far?
Yeah, we have gotten incredible compliments from the folks that are engaged with the selection process, mainly because, as I said, it would have been incredibly manual, reading charts, and we still have a human involved. I don't want this to sound like the AI is doing the selection and that's it. There is a human in the loop still that evaluates the right candidates, the right people to be put into these types of programs. But yes, it's cost savings, it's accuracy towards are they truly based on large chunks of data, the right candidates for it? So it's improving the patient selection for those given programs.
Like the Intermountain example, it's like a moving sidewalk. You still got to walk a little, but it's just making it a little easier for the clinicians and care managers to make the right decisions.
100%, yes.
So since UNC is identifying people who are best suited for care at home, let's bring in Ohad Pollack, who runs marketing and engagement for TytoCare, who, as I mentioned earlier, provides technology so that physicians can take care of patients while they are at home. Ohad, like how are you leveraging data and artificial intelligence to drive better patient adoption of the technologies needed to provide best-in-class care while at home?
Yeah, it's a good question. For us, AI was a key element from the get-go because with TytoCare, we actually replicating the experience just in the clinic. So the patient has to conduct a remote physical exam by itself, so taking like lung sounds, looking into the ear, into the throat. So there is a major behavioral change that we need to drive with Tyto, with the remote physical examination. What we have done with the AI from the beginning is, first of all, patient guidance. So in real time, we provide feedback to the patient, for instance, on the image from the eardrum or from the throat, and we get, like, using image analysis, we provide immediate feedback for the quality of the image. And it's very important because we allow both asynchronic and synchronic examination. So think about asynchronic examination, where you send all the examination, but they are not in good quality. So for us, it was a key element to ensure the adoption of this device, which actually changing the behavior of how you consume primary care by yourself.
Right. And what about how it guides the patients to making sure they're using it correctly?
It's like, think about it like an autopilot, or the systems that you have in airplanes that help flying without visibility. So this is actually like that. It's guiding the patient, depends on the type of the examination, and create a lot of trust with the process. So in each, it depends on the exams, but in most of our exams, there is some feedback loop for the patient using AI in most cases.
Great. And Karen, as I'm going to bring in Karen Murphy again, who runs innovation and digital transformation at Geisinger. As an industry, Karen, we've been talking about population health and risk stratification for a while. So I want to take us now from the home and bring us to just back to population health. Okay, so we zoomed in, now we're going to zoom out for a moment, and we'll zoom back in a little while too. But are there specific examples that you guys have where you're applying a true AI solution to stratify populations, to identify folks with chronic disease so that you could effectively target and engage them?
So we do, Eric. That is an area of focus for the Steele Institute for Innovation, is really to focus on the problem of chronic disease management and population health. And much like Rashina described going on in UNC, one of the pressing issues is really exacerbation of chronic disease, or an acute event trying to prevent ED and hospital admissions. So we have a large group of case managers, but we really looked and said, we want to be sure we're focusing on the right patients at the right time. So that is the value of a risk predictor. And our model that we created are patients, the sickest patients that we have in the home, being managed by care managers. We developed a risk stratification model that incorporates over 800 factors. And the prediction we're trying to make is what patient is at the highest risk for admission over the next 30 days. And that model then shares with the assigned case manager, these are your patients that are at the highest risk. Reach out, explain why they're the highest risk, and then implement the necessary interventions to prevent that ED or hospital admission. We've worked on it for over a year. The model continues to improve. We're at a 10% reduction in that group of people of ED or hospital admissions when we do a 60-day look back. So in other words, we take 60 days, evaluate what has happened in that group of patients, and identified how the utilization has changed. So it's a tool. I'm sorry, go ahead.
Could you clarify the chronic illnesses specifically? Do you have the list of them just so people could get an understanding if they want to think about it similarly?
Sure. So it would be patients, hypertension, diabetes, stroke, congestive heart failure, and they're not singular. They're usually multiple patients with multiple groups of chronic diseases. So we hope as the model is refined that we'll even be able to, will actually improve our statistics. Our goal is certainly to get a reduction greater than 10%, but really excited about the possibility. And the case managers are really satisfied because they now know what patients need their attention.
So cardiac and cardiometabolic diseases, it sounds like, if I could just classify them.
Yes.
First, was there a reason why you chose those? Was it just pure girth of the population?
When we looked at the reasons for in our population taken care of by our case managers, we identified reasons for frequent ED visits and hospital utilizations in patients with chronic disease. And that's how we selected the population and set up that risk stratification model.
That's good. One last question, because I know you guys have a close view. You have a health plan as well. Does the health plan have anything to do with this? Is there any collaboration with the payer side? Can you tell us a little bit of how that works?
Absolutely. So Geisinger is an integrated delivery network, which means we have a clinical enterprise and a health plan. This allows us to work on, we do run the risk profile on patients that are even taken care of outside of the Geisinger enterprise, but are covered by Geisinger health plan insurance. But the risk stratification model, we go hand in hand with the case managers and population health managers within the health plan.
Great. And I want to stay with the topic of prediction and get another example. So I'm going to bring back in Rachini Masavi. She runs analytics for UNC Health. How are you guys using AI for early detection of, you mentioned, you referred to HAI earlier in the show, patient sepsis, anything to do with just early detection to save people when they're in your hospital?
Yeah, no, I think it's such a critical thing for us to think about early detection for things like sepsis or just deterioration or other things that are happening in the hospital. First, I really do want to commend Karen on the program that they have at Geisinger. I think, being able to keep people out of the hospital, especially when they have comorbidities, is so critical. But things like sepsis, when a patient presents in the ED or is already inpatient, and is starting to develop signs and symptoms of sepsis, those are things that we need to be able to jump on as quickly as possible to really change the course of that patient's care. So going back to about 2018 or so, maybe even before that, we really started to work with our clinicians on the ED side, looking at the models that were already available to us, some of which had if they triggered 10 times for an alert within our EHR systems, that one of those patients might actually have sepsis. And that kind of level of false positive alerting starts to add to that alert fatigue. So we decided to build a custom model over at UNC Health, and we worked through it with our clinicians, specifically in the ED space, since that was one of the primary areas that we wanted to get a better control of identification of sepsis patients. And with that, our custom model, we were able to say that there's a 1 in 3 chance that a patient for which the sepsis BPA, which is a term we use, a best practice advisor, an alert that fires, actually will have sepsis. And so we drastically reduce that false positive rate, as well as improve the sensitivity of our model to be able to create improvements, as well as some confidence for our clinicians in terms of when the model fires, it will likely be true. And so that has really improved the use of our order sets for sepsis to be able to get the patients on some prescribed path to get them out of danger in those spaces. And then again, reducing the false positives, which helps with the alert fatigue, as well as all of the burnout that our clinicians are experiencing in healthcare.
Nice. I want to stay with early detection because I do think there's a huge impact that this technology, when applied right, could can make on our entire industry. Before I do that, I mentioned to you that our partner for this show is TytoCare, and they're a big partner of Bright Spots and Healthcare in general. We cannot provide all this great content and get all these great guests to join us without support from our corporate sponsors, and TytoCare is one of our best. They are, if you join us late, a virtual healthcare company, but a very special virtual care company. They enable health plans and providers to deliver remote healthcare to the entire family through their product that they call Home Smart Clinic. And this combines this cutting edge, easy to use, FDA cleared devices with what you've heard about today, AI powered guidance and diagnostic support. And this Home Smart Clinic enables the entire family to conduct remote physical exams with a physician, replicating the in-clinic exams for immediate answers right from the comforts of their own home. This drives utilization rates. In fact, they drive utilization rates around primary care and these exams 5 times higher than traditional old school telemedicine. They reduce total cost of care on average by 5%, and they divert ED visits by an average of 10.8, basically 11%. And they have an NPS of 83, as you could probably expect. It was going to be very high. And as part of the clinic, you get what is, I know, is near and dear to Ohad's heart, Tyto Engagement Labs. And this is this proven framework for engaging the member and helping them through their journey. This is where AI is so critical. It provides for successful deployment and adoption of their entire Home Smart Clinic. And then recently they decided, hey, we're going to provide the Pro Smart Clinic, which is for settings, professional settings outside of the home to help improve access and equity around this country in rural settings, schools, workplaces, and more. And if you think they're a small little startup, they're not. They serve over 220 health systems around the land, and not just the United States, but all over the world. And they support health plans around this country. They're in Europe, the United States, Asia, Latin America, and the Middle East. If you want to learn more about them, you can check them out at TytoCare.com. That's TYTO care.com. Thanks again for everyone at TytoCare for supporting Bright Spots in Healthcare. Ohad, I want to stay with early detection, like I said. How are you leveraging your big repository of data to enable doctors to virtually identify diseases early?
Yeah. So over time, we understood that we have a gold mine. So as you mentioned, we serve more than 200 health systems, and we have hundreds of thousands of families that we support that generate millions of visits over the years. So if we look at the type of the examination, the top examination is for respiratory, like lung sounds. And we have, I believe, the largest database for lung sounds in the world with more than 800,000 samples. And once we understood that we have over time, after we launched the product like 7 years ago, we got our first FDA cleared approval. We decided to develop decision support tools using this repository. And the first type of condition was wheezes, in order to actually identify in advance flare-ups of asthma and other conditions. And using this database, we invested for more than 3 years with data research. We use pulmonologists, like 20 pulmonologists that actually annotate the data. I believe that everybody will agree here on the forum that with a good AI is amazing algorithms, but one of the most important things is the data and the quality of the data. So actually we invested a lot with identify the right data, the right samples of asthma, without asthma, and we use the power of those specialists to actually run machine learning algorithm and identify wheezes that in a quality that it's not inferior to a primary care clinician. And this is how we got the FDA clearance for this capability. And we are now working on more capabilities like crackles and for ear infection, otitis media, identification and ear canal infection. It's all based on image and video analysis.
That's great. So far, folks, just in a short amount of time, we've heard how AI is helping identify pneumonia patients and providing physicians with triaging and best practice support. We are learning how AI is helping determine which patients can be taken care of best at home versus within the hospital. We are learning how doctors and patients can work together in the home through technology and AI. And then from early prediction standpoint, we've got colon cancer that AI is helping identify. We've got sepsis, chronic disease, all the cardiometabolic and cardiac diseases. And now we're hearing about, I'll call it just crackling and wheezing and things dealing with just asthma in general, all predictive through using AI. So this stuff is working and it's out in the market today. When applied right, can make a huge difference. And let's talk about the difference and the impact and the results. And I want to bring back Dr. Nathan Dean as a reminder. He's the section chief of pulmonary and critical care medicine at Intermountain Medical Center. Nathan, can you tell us a little bit about what Intermountain has seen since implementation of pneumonia and how you guys are looking at the results holistically and some of the things that you've been able to publish so that the rest of the world can learn more about it?
Yeah, thanks. We've published 2 papers. First, Annals of Emergency Medicine in 2015, which is the leading ED journal, and then last year, the American Journal of Respiratory and Critical Care Medicine, where we measured 30-day mortality. And the 2 papers were quite similar, estimating a relative decrease in 30-day mortality of 30 to 40%, which is absolute 2 or 3%. And then we've seen a shift of patients to safe outpatient care who previously would have been admitted to the hospital using the severity scores and encouraging physicians to recognize those who aren't that sick and don't need to be in the hospital. And so those are the 2 primary clinical outcomes. And we've seen changes in antibiotic prescribing as well with this.
It's massive. And now you started this over 15 years ago. So I'm not getting into the time value of money and all that, but can you just give the group, because this is a hugely impactful program at a very large, significant healthcare system in this country. Can you talk a little bit about the original investment and just a little bit behind the scenes on the ongoing funding?
Yeah, so we've had some industry grants to start with, and then funded by Intermountain as well, maybe $1 million to get pneumonia first developed, and then some more money in kind. Cerner did in kind support to program it into their EHR when we changed from our legacy system. Currently have 2 AHRQ grants, one, put this in the chat, one for spreading it to urgent care clinics, which we have a system of, and the second one to take it back out of an EHR and make it a Smart on Fire EHR interoperable program that we're going to have interface with Epic at Vanderbilt. So there have been a variety of funding sources. It's actually difficult to measure the financial side of these shifts in patient towards outpatient. We conservatively estimate over $4 million a year in our healthcare system. In the emergency department, we have about 5,000 pneumonia patients a year. And the more the patients are managed care as opposed to Medicare or a third party pay, the bigger the cost savings that Intermountain sees.
So conservatively, you're looking at a 3-to-1 ROI, but it's not all necessarily buttoned up, but just directionally.
Yes, that's correct.
I want to stay with impact and results. I want to talk about maybe how an effective application of AI and ML in the home is yielding better financial incomes. Ohad, can you speak a little bit to the impact that is being seen through using AI in the telemedicine realm? You're on mute. Someone was bound to do that. I thought it would be me.
So very quickly, so I can talk for hours about example for the impact and in total cost of care, etc. But I just want to share one very interesting study that was conducted by Stanford University together with Tel Aviv University that was published 2 weeks ago by the Journals of Health Economics after peer review. This study was conducted on one of the largest HMO in the world, that they have like 60,000 families with Tyto, and study was conducted on 30,000 families in order to examine what is the adoption together with AI, by the way, supported by the AI, and to compare it with the economics of traditional telehealth was audio video. Okay, so over 3 years, 30,000 families that conducted more than 100,000 remote physical exams with Tyto, in compared to 950,000 telehealth visits. And this study found that with the remote physical exam from home, assisted by AI for patient guidance, it was not included the AI for with detection. It came in a later stage. The study found that with TytoCare, we reduce total cost of care for the family with 7.1% for the whole family. And for adults, by the way, it was a big surprise for us, was 9%. All this study was a big surprise for us. It was conducted by third party. We were not aware about this. It was a good surprise. We see also a reduction in utilization in urgent care around 11.3, and in ED 24.1 reduction. And we were very encouraged from these results and the utilization. And we think that with the help of AI for adoption, good adoption and utilization, and bring trust with the remote physical exams from home.
Well, I want to summarize that very quickly, make sure and there's a couple of numbers I want to clarify real quick. So the study was comparing old school telemedicine with what I'll call new school telemedicine. That includes actual equipment in the home, AI guided, AI supported equipment in the home. And it compared 30,000 families that were using this equipment. And I forgot the number for the people using traditional telemedicine, but the number is obviously the end's pretty big. So I'm sure it would be statistically valid. You showed the AI generated telemedicine infrastructure showed a 7.1% reduction in total cost of care per family. And then you said 9% was, and I couldn't catch what
9% for the adults. Actually, we saw that the reduction is more in the adults if you compare it to kids. Usually it's the opposite in other, but it's really depends on the cohort selection, etc.
And then 11.13% reduction in urgent care, which I got, and 24.1% reduction in ED.
ED. Yeah.
Super cool. And that's the Journal of Health Economics. So your team gave Gene and I a summary of that study with a link to the actual Journal of Economics study in preparation for this episode. Are you okay if I shared that with everyone?
Yeah, with pleasure. Yeah, absolutely.
So I'll send you guys the PDF. It's a really nice summary if you don't like journal articles, but if you want the journal article, the link's there. I'll send it to you. Gene, why don't you put up a poll? We'll just grab anyone who wants it. We'll send that out to people. Incidentally, folks, I'm going to be sending you a feedback form at the right now. You probably see it in your inbox right now. You're going to get more reminders from me, and I know you're sick of the emails from me. Please take the 3 minutes to give us feedback on this episode. You're going to help us dictate programming for the rest of the year in 2024. We're looking at that real closely right now. We look at every survey respondents' answers. And then if you want an introduction to OHAD and learn a little bit more about how AI is being leveraged to appropriately make better use of telemedicine, just to pick his brain and pick his team's brain, I can make an introduction and you can set up a one-on-one call. I'll personally make the introduction. I just won't hand out that information. I'll make an email introduction between you and OHAD and his team. So you could do that all through the survey. But if you want this document, Press yes, and we'll get that to you. Rajani, I want to talk about now operations and overall operation efficiencies and how AI is helping that. So can you talk about how UNC Health is leveraging AI to create more efficiencies within your operational workflow?
Yeah, I'd be happy to. Yeah, so one of the big things that we've experienced because of the pandemic, and then digging out of the pandemic, and then some, was a backlog of perioperative cases. So OR scheduling has been at top of mind, at the forefront of one of the things that we have great opportunity to support and improve. And the thing that my team took on was helping to predict surgical case duration. So there's a lot of ways that we've done this in the past, some of which were maybe less mathematically and AI related. But by having our data scientists go in and build out a predictive case duration that we can then first build outside of the EHR, and now we are working to embed directly into our EHR. What it allows us to do is to understand better how long will each case take, and in doing so, it allows us to fit in more cases, which at the end of the day is the goal for any kind of surgical group. You want to have that efficiency in terms of, are we stacking our cases appropriately, which might be a next step towards some of our data science and AI build. But knowing how long a case actually should take is a big first step for that. So with our custom built model, which we are, like I said, mentioned that we're putting directly into our EHR Epic, we've seen some 28% improvements over what we were previously using. And in fact, it's even with the 2 or 3 locations that we've started with, we're about to push to a system-wide deployment of it once we get it into Epic. But even with those 2 or 3 locations, we're already seeing that our health for our health system, we've risen to the top 25% of hospitals for case duration accuracy, which is within 10 minutes, which is just a phenomenal result, not even having pushed across our system. So this is one example of, I think, how you can leverage AI to really improve operational efficiency, and we're hoping to do similar things in other areas of our hospital as well.
And scheduling is so huge. What are the keys, sort of like, is it all around having that strong in-house data science? Like, what were the keys to making sure this is working well?
Yeah, no, that's a great question. And I actually have this conversation with lots of different data and analytics leaders across our organization and outside of healthcare as well. But just sticking to healthcare for the moment, I think the first thing is to recognize that our opportunities for AI are not just in the clinical space, that we should be looking at bringing in AI for the operational areas, the administrative areas, the financial areas, in addition to the clinical areas, that as healthcare organizations, that we are still businesses, and this kind of technology can truly benefit the way that we look at our entire business. And in order to do that, the second thing that I'd point out is that you have to develop a process for identifying use cases that fit within any one of those 4 domains, and then figuring out how to prioritize it. So once you can gather your use cases, putting it on some kind of risk impact grid and working through the appropriate methods to figure out when do we move these forward towards development, and hopefully getting something in that will either automate or augment a space. The third thing that I'll throw out there is that having an in-house data science team is important to be able to do this in-house. There are a lot of vendors out there that provide solutions, and I think if you don't have the luxury of having your own data scientists, finding the right partners is important. And so really doing your homework to find what fits for your culture and your organization is a big plus. But if you do have the ability to build a strong data science team, there's a lot of benefits to be gained by having what they do, one, aligned to your strategy as an organization and the areas they're focused on, but 2, fit the culture of your organization as you co-build those items.
That's great. I want to stay with this topic, and maybe Karen Murphy, who oversees innovation and digital transformation at Geisinger. Karen, like, let's stay with this theme and create like an AI strategy blueprint for everyone. Like, so let's even raise it up even higher, because that was a really good, what Rajani shared with everyone. And I think everyone who's on the call right now, if they're going to go back and continue to build their business case around this, they need to have sort of a little bit of a guide. How would you write that blueprint for everyone? What are some of the key components that they need to be thinking about?
So I think the terrific part about today's call was each one of us provided examples that are real and impactful. And I think there's so much that we could be doing with AI that just because we could do it doesn't mean we should. So when we think about, and I think to be responsible with AI, I think the clinical cases, it's critically important, obviously, to have a diverse group of stakeholders when you're designing or looking at, first identify the problem that you're trying to solve. And it should be a problem within your organization, not one that you find a solution and then you try to look for the problem that it applies to. So I say that's number one. I think the second piece is this is evolving, and you really have to continue to educate the enterprise, not just the data scientists, but actually everyone in the enterprise on how the technology is evolving and what is the value proposition. So what are our biggest problems? How do we use this to solve our biggest problems? And then lastly, it has to be actionable. Whatever is the result, whether it be pneumonia, whether it be OR time, whether it be predictive modeling, data science can produce a lot, but it isn't always actionable. And I think to be sure that we're being pragmatic and coming up with actionable solutions is really critically important. And I think I would just say further as we evolve, I used to say, probably a year ago, if I'm not seeing AI every day, I'm not being very innovative. I think that applies now. My new word every day is generative AI, so that everybody understands that we're all innovative. And I think that applies to generative AI also. As we evolve and go into this new space, we have to educate, we have to be responsible, and we have to find use cases that create value.
Okay, that was great. I want to try to list those things one more time for our audience, and I may have missed a couple, so watch over me here. First of all, you said build upon some of the real life applications that are actually working today. The second was never plan this in a silo, create a cross-functional committee. 3, you mentioned integration into workflow, so important for any kind of technology integration in a hospital or health plan. 4, actionable information is the key, and making sure you're defining that is the key. I can't remember if you wanted data science in there or not, so I'm going to put that to the side and let you correct me when I'm done. You did mention potentially partnering externally, depending on what you need to do, and then making sure you're thinking in the use cases and how the use cases could be applied, in particular now for generative AI, which is sort of like at this point in the evolution of AI, the Cadillac. So did I capture all that? Did I miss anything?
I think the only other one that I would add is the education piece, how important it is to educate across the enterprise on what AI can do and how do we create value.
So, I hesitate to ask one more question, but Rachini, maybe in like a minute and a half, could you tell us a little bit about the future? Maybe give an example of what you guys are doing with, let's say, Microsoft in the last 60 seconds here to give people an example of like where we're continuing to move as an industry and quickly.
Yeah, happy to. So I mentioned that we are stratifying our use cases, putting it on that risk impact grid. One of the quadrants that we have is the partnership quadrant, recognizing that sometimes the risk is so much higher that we can't necessarily take it on internally by ourselves, but the impact is so high that we need to find those partnerships. So as we start to dive into some of those use cases, we've chosen both Microsoft as well as Epic to partner with to really develop some of those items. Some of the things that we're starting with for our internal development, which still leverages our partnership with Microsoft, has to do with our teammates, how we're thinking about our clinicians, reducing burnout, addressing shortages and other things that they need, helping them to be more efficient in that space. So it could be things like, can you get to the information you need to answer questions more easily? Can I understand, even from an HR perspective, the information that I might need to consume in an easy way? So for that reason, we've built our own internal ChatGPT private portal that allows them to connect to external information. And we're building out internal connectors back to our policies and our training documents for our EHR, as well as other things that can help streamline how our staff work every day. And with our partnership with Microsoft, as well as Epic, we're now talking about some of the harder things. Can we collaborate to do things like predicting risk in certain health segments? Or can we even think about the different aspects of how Epic works and partner with them on things like drafting messages that come into our in baskets? And as we know, with through the pandemic, that has exploded. That's a sheer number of responses that are sent to our providers. So those are just some of the things that we're actively working on, and a lot more to come.
Great stuff. Folks, if you want us to cover this topic more and more and get more detail, fill out that feedback form. Thank you to the four of you for putting in so much work ahead of time and delivering so eloquently and informatively today in front of our audience. Again, folks, you helped program this show. This episode, and we hope all the episodes you listen to inspire you to think differently, take some of these ideas, bring them back to your organization. This is how we improve healthcare for everyone around the country and around the world. We do this show for you. I always like reminding you that this is your Bright Spots in Healthcare podcast. Take care until next time, everyone.